abundantly clear this year is how connected our health and our environments are. Whether it's in our housing, our neighborhoods, our cities, how supported we are in our ecosystem impacts the state of health or of disease. That's why we've gathered together this next group of changemakers to discuss how we can create a more equitable and sustainable future.
So hi, this is Indu Subaya. I'm delighted to be here with Vanessa Mason. She's the research director for the Institute for the Future, and Andrew Trister, who leads digital health innovation at Bill and Melinda Gates Foundation. I'm thrilled to be talking to both of you about this issue of health for all, equity and access, both in the United States and globally. I'd love to start with you, Vanessa. You've been looking at this issue for a while, this role of power structures, if you will, in the US health landscape. And I was wondering if you could tell us what you think some of the most concerning areas are where we're underinvesting in health access.
Hi, everyone. Thanks for having me here. I'm glad to speak about this. So my research last year really looked at, in health in particular, where power is shifting, so the ability to drive consequences. And there were three forecasts that I really focused on that were of concern and of interest. One around this notion of hidden health challenges now being destigmatized. So when we think of things like mental health, behavioral health, substance abuse, infertility, even looking at the statistic that nearly 13% of Americans live with a disability and fewer than 1 in 5 of those are employed, we're really seeing this incredible outburst of inclusive design, inclusive innovation that really offers a lot of opportunity to be able to bring in folks who have not been able to participate fully because of their health challenges, fully because of the stigma attached to those health challenges, and certainly have lagged in terms of their economic well-being as well. And so really one example I think that's so intriguing about this is that I saw just so many startups that were really focused on addiction recovery. Some came out of Pennsylvania called like Behavior AI, really using things like data, wearable sensors, even using immersive media, all of these sort of technological alternatives to what has been a very typical pathway to substance abuse recovery. That's a pathway that traditionally has only been accessible to about 1 in 10 Americans, and the rate of relapse is still very high. So we have these sort of tech-enabled ability for people to address substance abuse disorder. It's this amazing opportunity for addiction to not be in the shadows. We've certainly seen it in our political campaign that now addiction is just getting a whole new human face to the sort of impact of it and what recovery can really look like. But we also see things like sham rehab centers where folks are going on Facebook to prey on people who have relapsed, expressly to pull them in and take their money and take advantage of the destigmatization of these health issues. And so it's sort of this hyper visibility that comes with these health challenges coming out into the light is that, one, it's offering a lot more options for people, folks who weren't able to access these interventions, but it also is bringing in a lot more scams and fraud and betrayal that really we need to be aware of as folks that are part of this healthcare system. The second arena that I really looked at too is just like, what can we be learning from other countries? I think especially with the pandemic, seeing how China has reacted to the pandemic in much more of a sort of technologically driven, surveillance driven, but very like health systems long-term focused lens. And so in the United States, we really don't necessarily have that sort of long-term view when it comes to the value of those health interventions, much less the sort of types of interventions into being sort of more short-term oriented and really oriented around like what are the sort of financial quarterly demands of maybe a hospital or a pharmaceutical company. And so just really beginning to take in and seeing social determinants of health being adopted as areas for serious investment within the healthcare system are very hopeful, and hopefully begin to take this sort of longer term view and tie that to economic incentives as well. And so the third arena that I looked at too is just as genetic and genomic testing tends to mainstream, costs are going down. 23andMe now is a Christmas present that people get for $99. But with that is the acknowledgement that there's very poor representation of racial and ethnic minorities in the reference data. That yes, is part of the consumer part of this, but what we're hoping in terms of a healthcare system is to get to precision medicine being more normal, more accessible. So a lot of this sort of targeted treatment to who we are at a deeply genetic level. But because we haven't included, just in this particular example, racial and ethnic minorities, you see companies like a Color Genomics that released a polygenetic risk score test to be able to assess for heart disease risk, but it only worked for people of European ancestry. So now we have things like diagnostics on the marketplace that are cut off from people who arguably are even more affected or more at risk of something like heart disease. And so we run this risk of further bifurcating our healthcare marketplace by not paying attention to the incredible impact of racial disparities as they exist now and really not taking those into account in the future.
Vanessa, thank you for that. We're going to be coming back to a lot of the themes that you raised there, the idea of technology helping to bring things out of the shadows, but there being trade-offs as well in terms of, valid information that's so easily accessible now, learning what we can from other parts of the world. And also in this era of precision medicine, how do we make sure we're inclusive and equitable as well? So Andrew, speaking through your lens, where you do a lot of your work in the global South, you're seeing other shifts. And you've been talking about the shift from population health management to a more comprehensive model of care delivery. What do you see as really driving this shift, especially as it relates to the role of the healthcare worker?
Yeah, thanks, Indu. Just as Vanessa was mentioning, the focus in other countries has largely been on health system strengthening. And that is absolutely true within low and middle income countries and those countries in which we do our work in the global South. So primarily, we have been focused not just on looking at how to aggregate data and make better decisions in the aggregate, the typical global health lens or population health management lens, but instead to use technologies to impact the care delivery right at the point of care. So, and that in many places where we do our work really does not relate to a facility. A lot of care is delivered right in the community. And this is a paradigm that we think could, in fact, export out of the LMICs into high-income countries as a tool that could break down the disparities and the accessibility issues that we see within the US that Vanessa was relating to. So in our work, we have been focused on the utility of smartphones, the availability of connectivity that can augment the health worker, who often is a volunteer or a less trained person, so not necessarily a physician or a nurse, who can go into the community and still provide a certain level of care that can provide this very front line, the absolute, not the minimum, but in fact, more of a median of care. So those things that people have questions about when they're care seeking can be answered quickly, and triage and diagnosis can then be done appropriately given the circumstances. We've been very focused on diagnostic testing in that construct. And so being able to go from a questionnaire about a symptom all the way to augmenting the ability of one of these health workers to perform a diagnostic test and then appropriately recommend either a treatment in the case, say, of a drug shop or a pharmacy, or potentially to go to a facility if higher acuity care is needed. And in that paradigm, we think that we may be able to keep costs relatively low, which is one of the major guardrails, as you can imagine, in a low resource setting, take advantage of an existing workforce without having to necessarily bring the workforce up, skilled up through education directly, but instead do this distributed educational plan on top of smartphone apps. And so that has been a lot of the work that my team has led at the Bill and Melinda Gates Foundation. And I might say with many, many partners, both multilateral, other funders, and many of the governments in the global South. And we do hope that now, certainly with the exigency that we've been facing this last year around COVID, that we're recognizing that a lot of these same tools could have applicability within, right here in the US even. And so we have been now working with HHS and a number of other high-income country governments to understand how these tools may lead to care in the home or in the community directly to reduce the disparities to access.
Absolutely. And I actually wanted to ask Vanessa to comment on the similar issue here of COVID. in the United States has certainly highlighted multiple disparities. But are there also opportunities that we're seeing, Vanessa, that ways in which we can apply technology to improve access and equity in this era?
Yes, I certainly think that we're seeing opportunities to apply technology. I think just having an open discussion about things like COVID tracking apps, like this ability for people to just be more aware of what's going on with their symptoms, things like where they've been, who they might have been in contact with, what kind of behaviors. Those sort of all help to build greater awareness, as well as starting to build more health literacy in this country. Generally, our health literacy is pretty low. And so I think all of us having to sort of be forced to learn things like social distancing and sort of like learning more about epidemiology and just the level of knowledge about public health and how health works is just gone up so much. And so I think that that's heartening that people are starting to learn that. I think it's heartening that seeing all this sort of mutual aid and a lot of the sort of ways in which like technology tools have been adapted or sort of used in different contexts to be able to do that, whether it's finding folks to neighbors being able to let text folks know and having texting channels around in neighborhood centers to be able to get groceries or to be able to get medicines and have folks check on them. Obviously there have been no end of platforms that have provided this in a strictly commercial sense, but I think what we're seeing now is sort of this shift away from commercialization and really looking at relationships and interpersonal relationships, community relationships, and how those are just incredibly both essential and necessary if we're really going to deal with the health challenges that we have ahead, which are, whether it's the next pandemic, whether it's just our incredible aging populations in this country and in Western Europe. We're all going to need to be more connected to each other and realize how we are connected to each other if we're going to get through all of the challenges ahead.
Absolutely. And Vanessa, I wanted to stay with you for a moment. When you speak about this idea of kind of, individual agency and empowering folks, you're also reminding us that we can't place an unfair burden on the individual, that the system still has accountability. And so how do you kind of, in COVID now with all of the, issues you raised, but also moving forward, how do we ensure the right balance between where responsibility lies? In this very complex kind of community model of healthcare that you've described?
Yeah, that's a big question that I'm sure Andrew would have a lot of case studies to really address with a lot of his community health work. But the way that I think about this is, it's sort of the age-old no man is an island. And so we have individual responsibilities for being able to make daily decisions about our health, but we need an enabling environment. So in the same way, if you were to start a garden, you wouldn't try to grow flowers in sand. Like you need to have fertile soil, like you need to have the necessary water. I think we need to think of ourselves the same way that yes, the plant is going to germinate and it's going to grow. Like we're all going to sort of move through life as humans, but we need support systems for things that aren't going to be possible to do alone. So I think specifically just in the investment, for example, that Kaiser Permanente has invested $200 million in housing because they know, of course, when homelessness affects their populations, they're just simply not going to be capable of making health decisions. And so I think taking that sort of oriented ability, sort of like, what are the pre-existing conditions, for lack of a better phrase that I'm thinking of right now, what are the pre-existing conditions that we need for people to actually be able to make health decisions? And I think that's where we can start thinking of the balance between individual rather than community-based kind of decision making. But honestly, I think it's going to be something that's going to be continuously negotiated now. It's going to be continuously negotiated over time. And ultimately, a lot of what technology has to offer is the ability to be able to negotiate and facilitate, like, what is the right balance between the individual and the community.
Yeah, Andrew, I'd love your comment on that as well, because clearly, here we are trying to sort of scale the role of the healthcare worker through technology, but how do the other kind of stakeholders and institutions, if you will, fit into that balance?
Yeah, it's a really, really great point, Vanessa. I think that this is one of the conundrums that we face in that, in the social compact, what is the level at which you believe that you can make the greatest impact? And so we have been focused on this individual with a health worker within a community, which is a village or a town. And yet we recognize that it could be at the level of a state or a country level official decision-making that could have the greatest impact at that one interface between a person and the caregiver. And that has been really, really difficult to go across all of those different scales and understand both where incentives are aligned and when they may be misaligned. And I think that this plays out in a really interesting way within the U.S. context. To your point, Kaiser Permanente, a group that is not for profit and certainly trying to care for their population as best as they can, yet don't necessarily have the impact that they could if they are at scale outside of their population if they had worked, say, directly with government in a lot of their well, I should say, if the government were willing to work with Kaiser Permanente, perhaps that would be like a more apt approach. So, fundamentally, what we have found in our work in the Global South is that we can only go so far when we try to activate communities directly. And so we do show, indeed, there are a number of case studies where among hundreds of community health workers, we may be able to demonstrate the utility of technologies and the greater reach and the better outcomes for the people in the care within those communities. But it's very, very difficult to imagine scaling that to, say, an entire state or to an entire country without governmental, at least approvals. But really, frankly, it relies upon governments taking this on and looking at this as a lighthouse example, something that they would want to bring forward. And so we have been fortunate to also have exemplar programs where government has really taken the lead. And some of these are, say, in India, we work in the state of Gujarat, where the Principal Secretary of Health has looked at the technologies as the fundamental element of care delivery in the community. And so has mandated just a few months ago, in the middle of all of COVID, requiring all of the community health workers within the state to use a technical platform so that data can be more real time, the system can be more proactive, and allow for greater surveillance, even in this case. And that, to us, is a sample of how we believe we could work hand in hand with government and with other funders and NGOs to demonstrate not just the technical feasibility of these tools and the impact that they can have on a small scale, but really scale it up and try to build the fabric upon which all people can gain access. That right now seems quite daunting, I must say, in a lot of the world. But I do believe that as these tools become more available, that we may see more governments recognizing the utility that they could have.
Absolutely. It really is a combination of all of the layers coming together. And these digital platforms really give us that opportunity. That said, Vanessa, I want to kind of come back to you about this idea of chronic disease and the whole person. You've talked a lot about kind of how we have to really look at the whole person. Tell me a little bit about the role of technology in enabling that. Again, I think there are trade-offs, to use your term of we can do more for the individual, but technology is becoming more invasive in our lives. So tell me a little bit about how you think about the best use of technology to bring the whole person into the healthcare environment.
Sure. So just in going back to some of the concerns I've looked at before, so I think there are opportunities to, one, sort of fully realize like what are the health challenges that folks are dealing with. Like, just in looking at a lot of the, Joe Biden gave his acceptance speech like a day ago. I've lost track of time. But it was amazing, the Twitter reaction, because a lot of people were just saying just like, oh my gosh, like the president-elect of the United States acknowledged transgender people. He acknowledged people living with disabilities. Like these are populations that don't really get discussed, that don't really have, technological innovations. Like they don't have the hottest Silicon Valley startup chasing after them to deal with, problems that they need to have solved. And so I think, that sort of whole person is acknowledging, well, like who are the people who are not being served right now? Like that's part of the whole person, or like who are the other people who we're not looking at? I think, the other sort of function of technology too, again, is, Andrew has talked a lot about this, like being predictive, like the ability to anticipate when things could be going wrong or when the conditions are right for some sort of risk to suddenly become more of a condition or more of a challenge. I think when we get to the point where technology actually is doing that for us, where we don't have to have this point of failure, where you don't see things like, certain communities have dialysis centers on every other corner because like people have so much uncontrolled diabetes or not aware that they're diabetic. And so it gets to the point that their kidneys fail or severely compromised. I think seeing fewer outcomes like that are signs that, or are arenas where technology could be doing a lot of work to better anticipate. And then I think the last part is, and just in thinking about the piece that I brought up around precision medicine and genetics, like, yes, it's about affordability, but it's also about a lot of like privacy related issues and a lot of ethical challenges related to that. And so I think technology is an ability for us to better understand, like, what is it when we talk about privacy? Like, how can we stop sort of having HIPAA both be an impediment and also the sort of cudgel that's used to not build technological infrastructure that could be more predictive and could be more whole person centered. And so a lot of those sort of, what are our values? Like, what needs to be protected? Who needs to be protected? And from what, under what conditions? I think technology, it may not be necessarily facilitating privacy conversations, but it necessarily is compelling us to have these conversations about ethics and morality and values that are necessary to actually have a health system that is going to be serving people equitably. And so I think, the pandemic, is this sort of flashbulb moment for all of us to have these conversations. But these are challenges that have existed in the United States for years and years and years. Racial health disparities cost $245 billion a year. They don't appear to be going away anytime soon. And so I think this is a crucial moment for all of us to think about, now that we do have all of these technological capabilities, what does it mean to actually have a health system, at least if you're talking about an American context, and more broadly than that, what is the purpose of a health system and what does it need to achieve?
Thanks for that. And a lot of sort of elements there into what goes into sort of whole person health, if you will. Especially thank you for bringing in the aspects of privacy. Andrew, in your case, when we think of kind of global health, the ideas of, addressing conditions like malaria and maternal and child health, they sort of come to mind. But you've talked a lot about how with technology platforms that we have access to now, we're kind of breaking down some of those silos and taking a different approach to thinking about health. And it's not necessarily kind of condition specific one-off, it's this broader approach. So help us sort of contextualize that and what are you seeing as opportunities as we move more in that direction?
So, again, I look at the traditional care delivery platforms in the context of LMICs, but certainly this relates to the US healthcare system as well, where one can imagine that the chief complaint, the presenting symptoms, the question that a person is asking when they seek care, that becomes immediately the very narrow focus of the encounter. And when we think about a primary care delivery system that could broaden the aperture to allow for when we train as physicians, the idea of doing a review of systems to understand more of the context in which the person is living, to ask other types of questions to see whether we might be able to screen for things like diabetes when a person might be coming with a different question, that then suddenly we anticipate that while those types of encounters might lead to more healthcare delivery, right? So higher costs and potentially more healthcare in general. That in the end, being proactive in that way could fundamentally reduce the downstream negative effects, the dialysis centers on every corner that Vanessa was referring to. And that, I don't know whether that's going to work, but that is at least something that we're asking about. Vanessa talked about something else really important in the very beginning, around the use of 23andMe and the color genomics polygenic risk score. And it got me thinking also, one of the things related to privacy directly is the idea of using these types of algorithms in a way that is not biased. And what we have found in a lot of the work that we're doing in low and middle income countries is that if we use technologies that were developed by the Silicon Valley startups, say, and try to just transport them directly to the global south, many of them fail immediately. And these are not even, questions around a polygenic risk score and trying to get genomics. Although I will say that there are some really interesting efforts that are just now beginning in countries like Nigeria to collect more representative samples, largely because I would say that on the African continent, on the genomics front, that there are, it's actually a much more diverse population than any of the even Western European companies have thought about. And so there are a number of startups trying to have as a public good the collection of genomic data to represent more completely the population that's on the continent. But even before we get there, we recognize simple things like taking a video and trying to make a representation of the heart rate, right? A pretty whiz-bang technology, I might say, right? If you could just, across this video channel that we're talking about now, we could run an algorithm and all of our heart rates would be measured. And, maybe you could see that mine is a little high because I'm talking and nervous, right? But that works on people that have lighter skin. And when people have darker skin, that may not work as well. A very simple thing to test. And so when our grantees have gone out and tried to do this, they are now collecting representative videos, not just of darker skinned people, but of people that may wear a headdress or wear a bindi, things that may in general be confounders to an algorithm that was trained, say, on the East Coast in the US with a bunch of graduate students. And so these are the types of efforts that we have recognized now that if we want to get to that end state of being able to have that predictive algorithm make the greatest impact, that the data themselves should be representative of the people for whom the algorithm is being built. And that is not just to say like we're going to bias in a different direction. It's simply to be thoughtful about the way that we collect the data up front with privacy intact, absolutely. And that is something that we work on and think about the ethics and so forth, because there's also always the risk of exploitation when we collect these data. And then to recognize too that this should result in a more highly accurate predictive component. And so in the context of how it is that we see these tools going out and really providing that care delivery, we do think that increasing the aperture and being able to do more is going to be possible as we collect these data and build these algorithms. And without that, I'm not certain that we'll necessarily be able to get to that end state where we, again, we do the review of systems and start to do more of this proactive care.
Vanessa, are there kind of structural approaches that you're thinking about in the United States as we enter this very data-intensive healthcare environment that things we can do to avoid bias?
So yes, I'm someone who's a little bit pessimistic on the ability to avoid bias. I'm just more of like, how do we actually make bias more transparent so we can actually mitigate it when we see it? And so part of that is not having this sort of like to think of it like algorithmic supremacy, that the fact that the algorithm is always objective and the algorithm is always right. And like, that's a human fallacy that we need to find ways of checking and handling. But outside of that, I think in terms of data structures, a lot of this comes down to, one, like what are our capabilities when it comes to computation? I think obviously like there's been no end of innovation in terms of cloud computing and ability to think about and use all of this data. But if you go to your garden variety community hospital or community clinic, they don't have the capabilities to be able to handle all of this predictive data. And so we need a proper data infrastructure that's going to be able to actually deal with this, like the sheer amount of genomic data that, in theory, we think that we're going to be collecting, and have that be actually actionable at the point of care. So I think that that's one arena and where we're thinking about like technical infrastructure, where there's obviously a lot of opportunities there. The second arena that I spoke about too is just sort of like privacy conversations, having a lot more professional bioethicists and a lot of data scientists who are thinking about bias and addressing that. But I also think this is an arena where we should be working more closely with patients. We have patient advisory councils for hospitals. There's really no reason why we shouldn't be having these when we think about data and what are the sort of new ethics when it comes to algorithms and AI and all of this data that we're collecting. And that, ultimately both needs to be, of course, bringing patients in, but also we need to be receptive to what they're telling us. Like, we need to find ways of actually having conversations like this where they're on an even playing field, and it's not just sort of technological jargon being sort of delivered to patients, and they're just expected to sort of pick up where scientists are leaving off. And again, I think that that's a human innovation. Like, we're going to need to find ways of communicating about complex technical information in a way that actually turns into robust action. I think those are two arenas that I could think about when sort of considering bias. And then, of course, obviously, like the U.S. government through my gosh, the name of it is completely escaping me, but they're really trying to collect more genetic data across the population and really collect diverse data and engage with populations. But I think especially now with the pandemic, there's a sort of huge erosion of trust in scientists, and a huge erosion of trust in what medicine is actually going to deliver. And yes, that's an arena for bias. If people really aren't kind of like picking up what you're selling and choosing to act upon it. Pfizer just announced today about their 90% effective vaccine, but let's see who's actually going to be first in line to go get this and what actually happens. And so I think technology's ability to sort of address trust data or trust and being able to provide either data or communicate about data in a certain way that actually increases trust is also helpful.
Yeah, this morning we received news, globally of promising results for a new vaccine. It's a potentially major turn in the fight against COVID. And the conversation around trust has been very fraught, in my opinion, in the United States, in terms of, for example, people's readiness to take such a vaccine. And I think it's going to be an interesting chapter as we explore what that word means and its implications in all the communities that we reach. So I'd love to come back to you, Vanessa, on this. But Andrew, in light of potentially the dawn of an age of a vaccine today with the news from Pfizer, how do you think about things that we do that build trust appropriately in communities? And I'd love, Vanessa, for you to expand on that as well.
Yeah, I'm so thankful for this, Vanessa, for raising this idea of trust. Actually, I don't know if you were thinking of the All of Us study from NIH. This is the one of the projects that I had the pleasure of working on prior to joining the Gates Foundation. And indeed, trust was at the very core. And so this idea of being transparent around bias, it has this. There is this. The mirror of that is, how is it that a community is looking back and recognizing whether this is something worthwhile for the community, for an individual, for just generalized scientific knowledge. And trust is at the very, very core of this. And we have been watching very closely how in the global South, in addition to the US, people are thinking about diagnostic testing first and the incentives around those, and then how that might translate to whether an individual may trust a vaccine and sign up. And incentivization is a very, very murky thing to measure. And what we have found is that in certain countries in the global South, there are, by all estimates, using serosurvey, very large numbers of the population who have been either active infected or have been infected with COVID, reaching 50, 60% in some communities. And yet the incentive to go and get a test to potentially reduce the transmission rate, to isolate oneself, is quite undercut by the economic implications that might have. So we have often in medicine believed that additional knowledge is better, right? If we knew, we would be able to take an action. But that action now, in the face of COVID, may not necessarily be what's best for the individual. And I think often about training, going through medical school and thinking about cultural competency, a course now that is required by the AAMC. But certainly one thing where I think that a lot of Western trained physicians really don't understand is, what exactly does that mean for an individual who may be living in a completely different context? And I think that is likely to be true also in communities that are either underrepresented in training or otherwise disenfranchised in the healthcare system as we think about it. And this is where community care centers and federally qualified health centers play an important bridging role, but that at the core of all of this, that disenfranchisement fundamentally leaves us to not understand what are the incentives to necessarily have more information or access to a vaccine. We believe that the vaccine on the whole is going to be good news. And certainly I don't disagree with that. I do think that this is going to be tremendous. But the hard work, I think, is going to be a lot around how is it that we gain the trust or help to educate individuals as to what the pros and cons are, to really allow for an agency to come back to the individual in the decision regarding what access to a vaccine might be. Of course, the foundation is spending a lot of effort on ensuring access first. Without access, there's really nothing. This is just an academic exercise to think about incentives and trust. But once that access is established, there are going to be massive questions with respect to who is it really first in line, right? And how should these tools be used? And if an individual so chooses, what happens if they don't want to have the vaccine because they want to see what happens with long-term effects, right? And maybe some other truly, reasonable scientific questions that we may not be able to answer for some time. And what implications that may have for the society and the community in which they live. And I think that this is, again, like coming back to this idea of the social compact. What is it really that we each individually have when we take our choices? Are they really just for ourselves? Are they for our neighbors? Are they for our community? And what risk is involved, both on an individual level, either to have the vaccine or not, to have a diagnosis or not, to potentially be transmitting? I think we're seeing this play out in all sorts of truly different ways, depending on community that we look at, right? In some communities, like the one in which I live, if you were to walk outside without a mask, you're pretty sure that somebody is going to say something to you, or at least give you the askance look, like why you're not wearing a mask. And that certainly is not the experience traveling even just 30 minutes from here. And I think that plays out in all sorts of ways when it comes to vaccination and recording of vaccination. The WHO is recommending having the equivalent of a yellow card for COVID vaccine. That then, does that become, the imprimatur that you need to continue to have a job? I mean, that may happen in certain places. So the incentivization can overcome the trust in some ways, because if economic activity is going to be tied to the fact that somebody has been vaccinated, with the risks that may be attached to that, what does that individual choice really mean if it becomes one that may be somewhat more coerced? And I think that that's going to be a really difficult societal ethical question. And I think that, just as Vanessa raised before, having professional bioethicists and having the space to dialogue on these topics, rather than just like plowing forward and applying our lens, saying like the vaccine is going to be good and make that judgment solid, I think that should elevate the trust level, at least to know that we can have the dialogue and that people can understand this. But that also, of course, allows then for all sorts of misinformation to come into that space. And I think that we have to continue to focus on the science and ensure that those people that have the opportunity to speak to these topics, at the very least, are bringing in not doubt, but fundamental, like, here is what we understand today, and here are the questions that we would like to get answered as we move forward, so that we can have that idea of the self-efficacy and the health literacy that Vanessa referred to earlier, that can be elevated in that space. And I'm hopeful that we will have now, going forward, in the coming months, continued dialogue about this, because it's only now beginning, right? That we're having that.
Absolutely. Yeah, this is literally the news of this morning. But so, Vanessa, I'd love you to, obviously talk about what complicates the conversation around trust in the United States, but also what are the sort of things we can hold on to navigate effectively around this topic moving forward. And then I'd love to just sort of wrap with both of you commenting a little bit on sustainability of all of these issues. How do we, really prepare for the marathon in the long run? So Vanessa, just your thoughts on navigating this issue in the United States more effectively moving forward around trust.
Sure. Yeah, that's a hard one. I think, drawing upon a practice that a lot that we do in futures, looking back to look forward, like where are there historical moments, like where we've, where science has been able to come, so quote unquote, save the day, like where science has been trusted. What were the things that we modeled? Who were the authorities that we relied upon? And kind of think about remind ourselves and remind the American public and remind the world that, we have had vaccines that have worked before. Like we have been able to trust in the science to produce them and to actually receive them. I think the sort of second thing that we can do in terms of addressing trust is honestly admitting our failures. I think that we need to have more public discourse about where science has made some very poor either ethical choices or choices in favor of either expediency or some other sort of values of whether it's like economic return or something like that, and just being honest about that and having a dialogue. It's like, this is how we failed, this is how we want to not fail you going into the future, and this is how we've chosen to address this. And I think the third thing is again bringing people into the process. I think Pfizer has been, to like think about specifically this example, like kind of issuing press releases. I've seen a lot of scientists like on Twitter saying, but show us the data. Honestly, the best thing you can do in terms of like helping bring people in, as scientists, for us to be able to understand this. A lot of the scientists that I've seen on Twitter have been very avid and effective communicators. So like having that be accessible to the public so that they understand and, performing that kind of translation function. And so I think the more that we can do, to Andrew's point that yes, knowledge isn't going to solve everything, but I do think that using transparency as a way to surface both either intellectual opposition as well as emotional opposition to vaccines are helpful. Like obviously we had a rather large anti-vax population before. I certainly don't think that has diminished with all of this. And that's also an issue that hasn't been necessarily undone by knowledge, but I do think that we've learned lessons from that. Like we've seen like when people leave anti-vax populations and then become more public and saying how they made that transition, that is very helpful. So I think finding parallels and other examples from things like that will really be helpful going forward with building trust.
Yeah, really great points and really helpful too, Vanessa. I wanted to stay with you as we wrap up on the last question. In healthcare, we're often talking about the high costs. We're often talking about, the constraints that we have with certain federally funded projects. But here we are, looking forward. What are the ways in which we invest wisely and rely on assets that make all of these changes possible and sustainable, so that it isn't sort of a fad, that we're going to go through sort of the equity, wish, as opposed to building it into things systematically moving forward.
Yes. And I think ultimately in order to invest, we have to, a lot of this is about changing how we think about this. I think a lot, even the language of health is this intervention. Well, of course, that's something that's time bound. It shows up at this moment in time. Here's an intervention for a period of time, you evaluate it, and then you're done. I think adopting a lot of the language of systems, thinking about health system strengthening, talking about long-term value. What does it mean for the next generation? Really adopting, what is the legacy of this going forward? I think really trying to orient ourselves around what does this mean over the long term? Who are we doing this for? It's not for our kids, it's actually for our children's children. That kind of language really helps to not just have this be something that's addressing the problem of today, but really is thinking about how are we building the world of tomorrow. A lot of that, of course, my work is excellent plug for futures work to be able to have a lot of that mindset shift. But I think more than that, as we start thinking about both vision and goals, but also the actions that we're taking, that needs to be constantly front and center, that these aren't actions. They're not reactions, they're conscious choices that we're taking. You see some countries, New Zealand released a well-being budget. I think Iceland has released one too. Of course, realigning our economic incentives to be more long-term and also incentivize for outcomes that purely aren't just maybe financial or economic in return, are also going to help this be not just a fad, but really about more durable sort of outcomes.
Fantastic. And Andrew, as a grant maker, as a large grant maker, how do you think about sustainability and just lasting change in the work you're doing?
This has been a really large area of focus for the foundation. Generally speaking, we have had some examples where sustainability of small projects that we have begun have really led to governments taking on the mantle. And so we've seen this as an example in a tuberculosis screening program that began in Maharashtra in India, that now the government of the state has taken on the full funding of that program. I think that there will be more examples of this, and the technical ability and the ability to demonstrate that the cost overrun, this is not the one-way technical ratchet that we see in the US healthcare system, where technologies always increase costs. Instead, by distributing the care and ensuring that there is more care delivered at the front lines, that ultimately the costs are going to remain relatively the same. At least that's our hope. And in so doing, we do think that sustainability can be built in. But ultimately, it is through partnership with government that we see sustainability going forward. And that it's hard without a proper marketplace where people can go and ask for care in a way that it gets delivered and that there's efficiencies that are built in, that instead this is a good that is that really should be part of what society is delivering for citizens. And that's the approach that we've been taking.
Fantastic. Well, I want to thank you both for having this really enlightening conversation with all of us here today. And I think it's a very exciting time to be having this conversation. So look forward to catching up with you guys once again in the future. Thank you.
Thanks.
Thank you.